Okay, lecture number 11. This will be our last one on chapter 22, physiology on the respiratory system. So we'll talk a little bit about this. Some of these things I think I've probably already alluded to in other lectures. Respiratory adjustments that have to be made. And exercise is obviously one thing that I've already talked about a few times that's going to influence your breathing rate and depth. When you exercise, you experience hyperpnea, which I remember eupnea, E-U-P-N-E-A is normal breathing rate. Hyperpnea is going to be a faster breathing rate or increase in ventilation. So increase in breathing rate and depth. So during exercise, you may have to increase that 10 to 20 fold, and you're going to take advantage of those inspiratory reserve volumes and expiratory reserve volumes to move much greater volumes of air in and out of the lungs with each breath. All of this works so well. All those chemoreceptors do such a good job of monitoring our blood chemistry and sending impulses up to the respiratory and your cardiovascular control centers that we're able to keep CO2, oxygen gas, and pH levels pretty much constant during exercise. You might think they would change dramatically, but these homeostatic balancing mechanisms work so well that those types of things don't actually occur. Interestingly, and you may have experienced this before, I know I have, even just anticipating exercise, like I'm getting ready to go for a run, the brain, your cerebrum up in here, will send signals down to those respiratory control centers and cause your breathing rate to go up, just anticipating exercise. Let's see, high altitude. So we've talked about this before a couple of times. We even had a test question about it when we were covering the blood. All right, so if you're from a lower altitude, like we are here in Alabama, and you go up to above 8,000 feet, that could cause acute mountain sickness because your O2 levels, your O2 concentration, the partial pressures are going to be lower up in the higher altitude. But really, you have to be above 8,000 feet. So it's not like going to the Smoky Mountains. You're probably not going to experience much of a problem with the altitude change. I'm laughing because my family, we took a vacation out to Southern California. Well, not just Southern California, but several different areas out in California during the spring of 2013. And we took a Hollywood Beverly Hills tour, and so they drove us up to the top of one of the low mountains over Hollywood and Beverly Hills. And while we were up there, there was a paranoid mom who was freaking out with one of her kids, worried that one of her kids had developed altitude sickness. And we were like maybe 1,200, 1,300 feet above sea level, probably not much more than Montesano. So I'm kind of chuckling remembering that. All right, so if you experience this, you may have headaches, shortness of breath, nausea, dizziness. You know, if your brain is not receiving all the oxygen gas it needs, then you're going to start losing some of your brain functions. Unfortunately, in severe cases, you can wind up with improper blood flow into the brain. You can wind up having that increased blood flow into the brain can increase pressure, and it'll put more fluid out into the cerebrum. You can wind up with cerebral edema, and that's not good. Your brain doesn't have much room to expand against the skull. Plus, if your brainstem gets pushed through the foramen magnum, that's not going to be, that could be very quickly lethal. Pulmonary edema can occur as well, swelling in the lungs, or accumulation of fluids around the respiratory membranes in the lungs. Acclimatization, that's how long it takes you to make altitude adjustments. Your respiratory system has to respond, and you have to make hematopoietic adjustments, which is a fancy way of saying we need to crank out more red blood cells. So your respiratory rate and depth have to be adjusted, and in the more long term, your kidneys are going to secrete EPO, and that's going to stimulate a red blood cell production increase in your bone marrow, as we've studied before. So we're kind of tying together some things we've learned in earlier parts of the class. Okay, COPD. We hear about this all the time on commercials, or I'm sure almost all of us know at least one person who is experiencing COPD. That stands for chronic obstructive pulmonary disease. So if you remember obstructive pulmonary diseases, that's where you cannot move air in and out as easily because the respiratory passageways, bronchi, bronchioles, are narrower for some reason. That can be due to constriction because you're having an asthma attack, or it can be due to the buildup of lots and lots of mucus and congestion when you have something like bronchitis or emphysema. In some cases, it can be irreversible. So if it's chronic and it's long-lasting, it can be an irreversible type of problem. So who get COPD? 80% of the patients are smokers. They wind up with dyspnea, where you have abnormal breathing, labored breathing, and the reason for that, they're having trouble ventilating, and so their breathing rate is being stimulated to increase, and so that's called dyspnea. Lots of coughing, frequent pulmonary infections. You're not able to clear the respiratory passages as well, so that's going to cause problems for you. Also, if you can't ventilate properly, that's going to lead to hypoventilation. So not hyper, but hypo. So if you are not exhaling out enough CO2 because you have COPD, guess what happens to the CO2 levels in your body fluids? Goes up. What happens to the pH? Goes down. So you wind up with respiratory acidosis from that. And that can be fatal if it's not controlled properly. Okay, this is a diagram which is showing you what happens during the two major types of COPD are chronic bronchitis and emphysema. And tobacco smoke, air pollution, if you live in an area with severe air pollution, can damage, these types of things damage the delicate tissues down in the lungs, and you wind up with constant irritation and inflammation that leads to bronchitis. So because of inflammation, you have a buildup of fluids that triggers coughing, bronchospasm, air passages constrict due to the irritation, which just makes it even more difficult for you to breathe. So that's not good. In emphysema, you have a breakdown of elastin in the connective tissue, so those filler spaces in the lungs, your lungs become less elastic. And that's not good either. You know, you need your lungs to be elastic so that they can rebound when you're exhaling. If your lungs are not as elastic, they're not going to be able to deflate as easily, and they need to deflate to push air out. You also have in emphysema, you have destruction of the walls of the alveoli. So all that cigarette smoke coming in there kills those little very thin, paper-thin cells in the alveoli, and you wind up losing some of those in emphysema as well. So you wind up with dead air being trapped in the lung, air where you're not having gas exchange taking place. So all these things combined together cause abnormal labored breathing, frequent infections. Your airways are obstructed because of this. This leads to hypoxemia. What do you think that means? Anytime you see emia like that, that's referring to blood levels. Hypo, low oxygen, low oxygen levels in the blood. Hypoventilation, you're not ventilating properly because of these problems with the chronic bronchitis and or the emphysema, which, as we talked about, that can cause the pH of your body fluids to drop because you're not getting rid of the CO2 properly. There are some people who develop emphysema due to a genetic defect, and they don't produce a substance called alpha-1 antitrypsin, and antitrypsin counteracts some of the damaging compounds that are made by the immune system. And so if you have chronic bronchitis or emphysema for some reason, like through cigarette smoking, and you also have this genetic defect, basically this is supposed to, alpha-1 antitrypsin is something that's supposed to keep inflammation under control, and you don't keep the inflammation under control, so you wind up with more of this going on, and it just winds up exacerbating or making the COPD even worse. So that is a genetic defect that occurs in some people and can make these conditions worse than they normally would be. Okay, asthma. We've already talked a little bit about asthma before, and it's like a severe allergy type condition where irritants cause the bronchial passages to constrict abnormally, so when it's not beneficial. And this winds up leading to coughing, labored breathing, dyspnea, wheezing, chest tightness. Your chest feels really tight because you're not able to ventilate properly. And again, it is inappropriate inflammation that's being triggered by whatever it is that triggers your asthma attacks. That's ongoing, and then that leads to the bronchospasms, where the walls of the bronchial passages are constricting and causing a problem obstructing airflow. Also, whenever you have inflammation, you have excess fluid release into those tissues, and that excess fluid associated with inflammation, all that mucus and so forth, is called inflammatory exudate. That's another term for that, and that just makes it even worse. So that obstructs your air passages even more. So that's why asthma is so serious. It's an obstructive type homeostatic imbalance. This is a really gross picture, but this is showing you what can happen inside the lungs of patients who are infected with tuberculosis and have a very severe case of it. So tuberculosis is caused by a type of bacteria called Mycobacterium tuberculosis, and you will no doubt talk a lot about this organism when you take your microbiology class. It comes up quite a bit because it's been around for thousands of years. It's killed more people than any other type of bacteria that we know of, and it's pretty difficult to control. It's a pretty resilient type of bacteria. So if you have this, it sets up shop down in the lungs, and some symptoms: you would have fever, night sweats, you tend to lose weight because you have all this inflammation and your immune system is trying to attack these tuberculosis bacteria and clear them out, and that's going to lead to a lot of metabolism and use of energy that will cause you to lose weight. A hacking cough, which spreads the bacteria around, and in severe cases you actually wind up spitting up blood. So treatment takes a long time to get rid of this type of bacteria, and they're resistant to a lot of antibiotics, so it can be a 12-month course of antibiotics to get rid of it. And I know this is really gross, but in severe cases you basically wind up with this ongoing battle between the bacteria and your immune system that's trying to get rid of them, and you kind of have a stalemate situation that develops between the bacteria and your immune system, and your immune system tries to wall off the bacteria, and it creates these pockets called tubercles in the lungs where it's trying to compartmentalize off the bacteria from healthy lung tissue. But then the existing lung tissue inside those compartments liquefies and takes on this nasty consistency you see there in the photo. That's one of the hallmarks of a severe case of tuberculosis, and obviously that can be fatal if not treated. Lung cancer. It's hard to talk about the respiratory system without talking about lung cancer. This is actually the leading cause of cancer deaths in North America, and 90% of lung cancer cases are believed to be the result of smoking, so something to keep in mind. There are three common types, or the three most common types, and you'll hear people use this terminology. Squamous cell carcinoma, about 20 to 40% of the cases. So the cells, the epithelial tissues of the bronchi, the bronchioles and so forth, and even down into the alveoli, those are squamous cells that make up those linings. And so if one of those cells starts dividing in an out of control manner, becomes cancerous, and starts spreading elsewhere in the body, that's called squamous cell carcinoma. You can have that. Now, you may remember that term as well from the skin. So anytime a squamous epithelial cell becomes cancerous, it can be a type of squamous cell carcinoma. An adenocarcinoma, remember the adeno hypophysis or adenohypophysis in your the anterior pituitary. Adeno refers to some sort of secreting structure, a gland, a secreting gland. And so this is going to be a cancer is likely developing from a mucus-producing gland in the lungs. That's about 40% of the cases. And small cell carcinoma, about 20% of the cases, they're little small lymphocyte-like cells. Lymphocytes are very small for human cells. And they start out in the primary bronchi, the big ones, and subsequently they move away from that area and into other tissues. They're metastasizing. That's what metastasis is, spread of cancer cells away from their original location. So those are your three main types of lung cancers, and all of them are very serious. Okay, just a couple of things about development. 40 weeks is a normal gestation for a developing fetus. By the 28th week, if a baby is born prematurely, it can breathe on its own. Now, while you're a fetus, obviously you don't have, you're sitting in amniotic fluid, and your lungs are filled with fluid, not air, obviously, while you're a fetus in the womb. And so the lungs are not being used for gas exchange at that point. And we talked about that a little bit when we went over the cardiovascular system. So instead, the mother has the placenta in the womb, where there's gas exchange and nutrient exchange and waste exchange going on between her blood and the blood of the fetus. And the fetus's blood passes through the umbilical cord and into the fetus through the eventual belly button. And that's how gas and nutrient exchange and so forth occurs between the fetal blood and the mother's blood. And we'll see more of that when we cover the reproductive system at the end of the semester. Okay, when you're born, very quickly those respiratory centers are activated, because it doesn't take too long. As soon as you're born and the mother's placenta is no longer doing gas exchange for you, guess what builds up really quickly? CO2, because that newborn baby cells are metabolizing and generating CO2. CO2 levels go up. Chemoreceptors detect that. They send signals to the respiratory centers. Let's start breathing. And the breathing rate is supposed to begin. Respiratory rate, highest in newborns, slows down when you reach adulthood. You actually continue to mature your lungs and develop more alveoli until young adulthood, but then that reverses as you get older. Your lungs become less compliant, as we talked about earlier, and you're going to lose some of your alveoli. That's going to lower your lung capacity, and that's why you just can't breathe quite as well. You can't ventilate as well as you get older. All right, so that concludes the physiology for the respiratory system. If you haven't done the anatomy, hopefully you've done the anatomy already. If you haven't, it's not all that extensive, so be sure you do that. And please be sure to read through the study guide that I have posted on Blackboard for any pointers or assignments, research assignments I may have for you about disorders and so forth, so you can be as prepared for the exam as possible. And as always, if you have questions, please let me know and or post them on the Piazza discussion board so everybody can benefit from them.